Welcome to our panel on breakthroughs in the brain about new approaches and treatments for brain disorders at a time, I think we'll all agree, when many conditions are at or reaching crisis levels in our country and the world. So I am Betsy McKay. I will be your moderator, facilitator today. I am from the great class of 1983. I'm a writer, reporter for the Wall Street Journal. I cover public health and medicine. And so we have I am honored to be joined by two leading experts here. Emily Stern, also of the great class of 1983. And a class of 2018, right? Parent,
yeah.
Yes. Is Chief Executive Officer of Ceretype Medicine, did I say that right? Neuromedicine, sorry, which is revolutionizing psychiatric and neurological medicine with using advanced technology to find personalized treatments, and she will tell you all about that. David Silbersweig, a class of 1983 spouse, and which is its own alumni group. They should have their own tent. And also class of 2018 parent, is a psychiatrist, neurologist, and chairman of the Department of Psychiatry at Brigham and Women's Hospital and Harvard Medical School. We had a third panelist in the program, Michael Sernyak, but he was unable to make it, unfortunately. He sends his regrets, but he did provide some input for our discussion. So we'll just make a couple comments before we start. This is a really timely topic right now. This room is packed, which we're really grateful for, and I think we understand why. Number one, we have been through and continuing to go through a pandemic that has been a breeding ground for anxiety, depression, social isolation, fear, and we've seen a lot of wouldn't say an explosion, but certainly an increase in diagnoses and concerns about brain disorders and mental health issues. Second thing is our population is aging. We'll talk also about neurodegenerative diseases, which are on the rise in this population. Number three, because of all these factors, demand for treatment and access to treatment is of growing concern. Many people who need treatments and need help don't have access to health care, as you know. And the fourth thing, which we will talk a lot about today, is that technology is here to save the day. Technology is literally opening doors and windows to new possibilities, new ways to understand what's going on in our brains, and potentially new ways to treat it. So Emily and David are going to speak for a bit about the work that they do. Then we'll have a moderated discussion, and then we want to open the floor to questions, give plenty of time for that. There are a lot of people with medical expertise and generally smart people in this room with good questions. So get those ready, and I'll turn it over to you, Emily and David.
Thanks so much, Betsy. Thank you, Susan, the whole reunion committee for putting together the panel, for putting together this amazing reunion. We are so happy, so honored to be here. It's a real privilege, and we look forward to telling you a little bit about what we do. So we're going to start with a few slides just to give you some context and background to get an idea of the kind of work that we do, and then we'll open up the discussion as Betsy described. So a couple of disclosures first. So I am the CEO and co-founder of Ceretype Neuromedicine. This is a spin-out from Brigham and Women's Hospital, Harvard Medical School, and just a couple of other words about myself. Before spinning out Ceretype, I was actually in academic medicine for my whole career, developing and applying novel imaging methods to better understand the neurobiology that underlies neuropsychiatric disease. David is still in academia. He'll say a couple more words about himself when he comes up here, but his disclosure is that he's a co-founder and is head of the scientific advisory board of Ceretype. So Hippocrates was pretty remarkable because at a very early date, he was the first person who really recognized that things like perception, thought, cognition, behavior, emotion come from the brain. Before that, people were hypothesized comes from the liver, comes from the spleen. But he said, and men ought to know that from nothing else but thence from the brain come joys, delights, laughter and sports, and sorrows, griefs, despondency, and lamentations. And he went on to say, and by this we acquire wisdom and knowledge, and see and hear and know what are foul and what are fair, and by the same organ we become mad and delirious, and fears and terrors assail us. So not only did he realize that these normal functions come from the brain, but that those things that are so devastating and can be so traumatizing to us in terms of our mental life, in terms of what he's describing, it's essentially mental illness, that those come from the brain too. And so this is really our first documentation of this kind of thinking. And since then, different artists/scientists have tried to come up with ways to better understand how is this, where is the normal function, where are the diseases. This particular scientist put normal functions inside the brain and arrayed all of the disorders around the brain. So we've been trying to figure this out for a very long time. And with good reason. These diseases are common, they're devastating, they're tremendously costly to society, and they really are a huge public health problem, as Betsy was describing. So you don't need to look at all of the details of this table, it's sort of small, but the take-home point is that 4 out of the top 10 causes of disability worldwide are due to psychiatric disease and addictions and alcohol use. Number 1 is depression. So people don't tend to realize that depression causes more morbidity across the globe than cancer or heart disease. And at the same time, things like substance use disorders are huge. The opioid epidemic has been really significant. These are data from 2019. Over 70,000 people in the US died. Over 1.6 million had an opioid use disorder, and so on. So these disorders are just prevalent and they are growing. The costs are also staggering. So not only do you have costs associated from the emergency room care and the hospitalizations itself, there are costs from incarcerations. And again, something that's really underappreciated are the comorbidities that go along with mental illness. So medical comorbidities, over $130 billion per year. Lost productivity. These are the numbers from which the World Health Organization on the table on the previous slide comes from. Almost $200 billion a year. And not only that, it's predicted that in the coming years, mental illness is actually going to be higher in terms of its prevalence and disability than any other disease. So these are really, and we wanted to show you some of the statistics so that you can get a sense for how problematic this really is. Another thing that's, I think, very timely for us just to touch on is that, as we all know, COVID has not helped the situation. These are some data about young girls aged 12 to 17. Emergency department visits for suspected suicide attempts went up 51% over the course of 1 year. And in addition, young adults who we know have been disproportionately affected by the pandemic are more likely to report symptoms of anxiety and depression than older adults. And so 18 to 24-year-old group, 56.2%. So it's not just the adult population, but our children and our teens are suffering as well. And another thing just that it's important to touch on is that there are a number of socioeconomic pressures that lead to really unfair stressors and disparities in terms of mental health, both prevalence and care. And so things like racism, discrimination, violence, poverty all have an undue outsized effect on underrepresented groups. And not only that, but these groups are less likely to seek out mental health care. So this is just an important component of the mental health crisis that we have to always have at the front of our minds. And we've been talking about mental health, but neurologic disease is also tremendously prevalent, tremendously disruptive, and causes a lot of disability. So up to 60% of adults have some sort of neurologic disorder. And just to point out a couple of important ones, Alzheimer's and other dementias, 3 million people in the United States, Parkinson's, 500,000 people, traumatic brain injury, stroke, multiple sclerosis, etc. So these are all very prevalent diseases, and the point is that brain diseases are just common across the board. The other thing that I think that's relevant for people in sort of class of 83 stage and onward is that dementia is increasing. And so while we're in the, presumably 1.3% sort of incidence or prevalence of dementias at this point in time, this is only going to go up, and it goes up exponentially as we age. So all just important things to keep in mind. So what have been some of the obstacles and limitations that have made these problems so hard to address? Well, if we start with psychiatric disease, there are a few things. The first is that mental life, behavior, thoughts, emotions, these are complex functions. It's hard to understand the biology, and it's taken us more time. Symptoms tend to be subjective, so they're described by the patient, and they have that subjective side to them because there isn't any visible brain region or any test up until now that we've been able to use to tap into identification of what's going wrong. Our classification system, how we categorize these diseases, is descriptive. It's based on a book, the Diagnostic and Statistical Manual. And the way you diagnose a disorder is you say, okay, if you have 3 of this kind of symptom, 5 of this kind of symptom, et cetera, then you fall into this category, and that's your diagnosis. That's really different from the rest of medicine where you have a test. And then there's this concept of residual dualism. We tend to think of sort of psychiatric diseases in one bucket, neurologic diseases in another bucket, because you can see neurologic diseases, for example, on a scan. You can see a stroke, you can see a tumor, you can see an area of abnormal tissue with epilepsy, for example. Whereas in psychiatry, you don't see a gross lesion in the brain. But as we'll see, we now do have tools to allow us to see the abnormal biology, and that's what's going to change things. And so we can start to think of the brain as one organ. There aren't separate neurologic, separate psychiatric diseases. That's just how we see them and describe them. All of the abnormality comes from the brain. And then finally, there's been a huge amount of stigma associated with psychiatric diseases over the years. I would hope that with the mental health awareness that has come with COVID, we're starting to chip away at that, but it's still an issue. So what is it that's missing medically? For virtually every other disease in the human body, we have tests to tell us what is going wrong. So these are biomarkers. They're ways for us to look at, for example, blood vessels in the heart for cardiovascular disease, or doing an EKG, we can get measurements. If we suspect cancer, we can do a scan to see a tumor. This is a scan showing a lung tumor. And then we can do very sophisticated tests like molecular profiling to help us identify specific patterns that are present in the genetic makeup of tumors to help us target therapies more effectively. But as I described, where are we in neuropsychiatry? We're still describing symptoms and making diagnoses based upon those subjective responses of the patient. So this is where some of the technology comes in. We have spent our careers, and one thing I should say is that David and I have worked together really for pretty much our whole careers. I'm a radiologist and a neuroscience researcher. David is a both a psychiatrist and a neurologist, if you kind of draw a Venn diagram between those, functional imaging is right at the intersection. We're able to use something called functional MRI scanning, which allows us to look at brain function in addition to just brain structure. And we're not going to go into the details of how this works, but basically when particular areas of the brain are more or less active, there's an increase in blood flow to bring more oxygen to those areas. And it's the change in the characteristics of the oxygen when it's delivered and then when the oxygen is extracted that are measurable with an MRI scanner. So every time you have a change in nerve cell activity, even in very small areas on a millimeter scale, you can get a reflection of that or a measure of that with fMRI. And so this is really amazing. You don't have to inject anything. It's completely non-invasive. We use the physiology of the brain itself to give us the measurement. And this has really opened up a whole new world for us to understand these disorders. So, of course, we're not working in a vacuum. We also work with basic scientists who do work in animal models. You can look at microscopy, you can look at different markers in different kinds of molecular or cellular markers, et cetera. One thing to be aware of, though, is that our animal models, particularly of psychiatric disease, are limited. There aren't great ones, and that has made it a challenge. What we're doing is we're working at what we call the systems level. So we can actually see what's going on in the brain with fMRI in particular regions of the brain, nodes of a circuit, and we can see how those regions interact with each other in terms of their brain activity, their connectivity, etc. So we're not looking at things through a microscope, we're looking at things at the level of the whole brain. And so with that, I'm going to turn over to David, who is going to tell you a little bit about how we can apply this in much more specific ways to some of these disorders.
Thanks. Thanks, Emily, and thank you so much for orchestrating this and inviting us. It's really wonderful to be able to speak together. What I'm going to do now is give you some examples, and they're really just illustrative, and we're going to go through a quick tour because we want to leave a substantial amount of time for dialogue and questions and discussion. And this is just to be able to show you that, as Emily said, we're in an era now, and the reason I trained in neurology and then to bring this to psychiatry and neuropsychiatry is where we can localize what's going on, and we're realizing increasingly that it's not just one area, that these are whole networks that compute, if you will, and in which there are emergent functions, and we're able to study even things like consciousness and morality and subjective experience, relationships, things that were thought to not even be amenable to empiric investigation. So all of that said, with any technique or any technology or any science, one needs to understand the limitations, and one doesn't want to make premature claims. So it's very important to say that we're not there yet in terms of biomarkers for psychiatric disorders. We're laying the foundation, and people in our field are laying the foundation. And that's really what we're going to be talking about today. And it has a lot of implications, as you'll see. So this was a study where we wanted to understand the regions of the brain involved in hallucinations and schizophrenia. 1 to 1.5% of people in the world, regardless of culture, have schizophrenia. Psychosis is a prominent feature, which includes delusions and hallucinations. Hallucinations are seeing things that are not there or hearing things that are not there, usually voices in the case of patients with schizophrenia. What you see here is a picture in which, can you see my mouse there? Yeah. Mm-hmm. In which in gray is the MRI of a 24-year-old male patient seen from the side like this, right? That's the brain. the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe, the brainstem, the cerebellum. Don't worry about all of these things. Brain from the bottom, brain from the back. And this unfortunate young man was hearing voices and seeing images of people and faces that were sort of dissolving and speaking to him in colors. And, you know, what we're able to do, and long story short, in this case, and this was with PET scanning, is have him signal every time he was hearing the voices. And the button press, for those of you who know neuroanatomy, in the left precentral and postcentral regions here is signaled here. You can control for that. In the back of the temporal lobe in the brain, in areas we call the superior temporal gyrus and up into the temporoparietal region, the angular gyrus, those areas are active in you right now as you're processing my voice. The auditory nature through hearing, the linguistics, the decoding the phonemes into semantics, right? But no one was speaking, it was silent. But these areas of his brain were statistically significantly active. It was dark and his eyes were closed, and these areas of the brain, which some of you may recognize as visual areas of the brain, even down to areas of specificity of the color areas of the brain, the motion areas of the brain, the face areas of the brain, the exact thing that he says he was seeing, are active. And then we have other deep areas of the brain that are very involved in, and other areas of the brain involved in paying attention to something, in memory, in conscious awareness, and in the emotional components of these, which are very meaningful to patients, and the salience that is ascribed. Patients with other kinds of hallucinations in some neurologic disorders say, "Doc, what's wrong with me? I'm seeing things, I'm hearing things." Patients with schizophrenia believe that it's actually real. And so we need to understand that, and we think that part of that is the failure of activation, the reverse, decreases in key areas of the frontal lobe that are involved in monitoring your own mental activity and controlling some of these other areas that I've just talked about, which are auto-released, if you will. And so is he, quote, crazy, to use a term we don't use anymore, but I'm using it for effect right now? No, he's just telling us what his brain is telling him. If you were to stimulate our brain in these areas, and in fact, a famous neurosurgeon, Penfield, in the 1950s did that in patients with epilepsy who were undergoing evaluation for surgery. If he stimulated this region and they were awake, which they were for that, they said, "Oh, I'm hearing a voice." So we're hardwired, right? That's the point. There's software too, if you will, and there's a lot of neuroplasticity, but these are important things to keep in mind. Another big symptom of schizophrenia is delusions, fixed false beliefs despite evidence to the contrary. And we wanted to test the hypothesis that threat areas of the brain that are evolutionarily preserved and adaptive to tell you if a lion's running after you or if you're in danger, including social danger, etc., were aberrantly active even when they shouldn't be in patients who had paranoid delusions. And to make a long story short, it turns out that that's true. These are areas called the amygdala, and you may have heard a lot about this region as a region being involved in fear and threat in addition to other things, and it's on fire, if you will, in patients. And these areas, again, in the prefrontal cortex that should be modulating are asleep at the wheel, and this is a common theme. There's a yin-yang, and some things are out of balance, and you get these phenomena. So again, are the patients, quote, crazy? No. Is it their fault? No. Their brain is labeling something as threatening, and they are responding appropriately, as you or I would. It's just to things that shouldn't be actually threats. Strikingly, even with psychotherapy, right? In this case, not sort of old type psychoanalytic therapy, but cognitive behavioral evidence-based therapy, you can show, and this is a study we did looking at patients, and this is one patient before and after cognitive behavioral therapy for paranoid delusions. And to make a long story short, this is cut through the brain, what we call coronally this way. And you can see that after compared to before, there's an activation of these higher order thought areas that are involved in executive reasoning and control and monitoring of your own mental activity, and a corresponding diminution in areas that are part of the so-called salience network in the insula and the amygdala, these emotional areas. So literally, what you're doing in cognitive behavioral therapy is training the brain to use its higher order functions to calm down the inappropriate hyperactivation of the more limbic functions, emotional functions, if you will. And what's so cool about this illustration, or the concept behind it, is this is psychotherapy. It's not a medicine, not anything else. But unless you're a dualist, you would have to say, well, it has to affect change through the brain. And so these are very powerful sorts of things. We can also study major depression. And to make a long story short, depression is not just exaggeration of negative emotion, it's failure of positive emotion, right? There's something called anhedonia, which is lack of interest or pleasure in usual activities, the things that a patient might normally love to do. Go out with friends, go to the movies or something, they have no desire to do. And to make a long story short, we and others have shown that the reward networks in the brain, that the motivational networks in the brain that are involved in some of these areas called the ventral striatum or nucleus accumbens, some of these deep areas in the basal ganglia that are very dopamine dependent in terms of reward circuitry, are asleep at the wheel in patients with this. And this also has implications for treatments. The medications modulate this circuitry too. And Emily will talk more about this, but we're in an era where you can start to look at the network characteristics of these nodes and brain circuits, and even hopefully develop predictors of who's going to respond or not. Instead of giving a patient an antidepressant and crossing your fingers and hoping that within 6 to 8 weeks it'll kick in, and in the meantime there could be disaster, we may be able to say, you know, Mrs. Smith, Mr. Gonzalez, you're going to respond to this medication because you have this profile of brain activity, and therefore you should get this medication because it modulates the circuit in the way that it's disrupted in you, just like we do for other diseases. So we've talked about psychotherapy, we've talked about medication, and now a very big area right now is brain stimulation. A close colleague of mine, Ben Greenberg here, who's an alum. What class, Ben? 78, okay, is a leader in OCD circuitry and this sort of thing. At the Brigham, we're doing work, and Sean Siddiqui in my department is actually able to map out whole networks of the brain and how they're toggling back and forth in terms of what's called the connectome, the human connectome, and that there are different profiles for depression that distinguish depression, and even within depression, different subtypes and different symptoms of depression, so that for certain patients, they may need brain stimulation exactly here or here. There's different kinds of brain stimulation, which I won't go into. You may have heard about deep brain stimulation, where you insert electrodes into the brain, but more non-invasively, and something that we're doing a ton of now in research and into clinical practice, is transcranial magnetic stimulation, TMS. And that's where you deliver magnetic pulses over the head, and the brain is an electromagnetic organ, and you're able to modulate and even induce plasticity, changes in those underlying circuits. And then at the Brigham, we're doing something else called focused ultrasound now, where you can even deliver energy through ultrasound and modulate these circuits as well. Switching over to neurologic disease, just one quick illustration that in Parkinson's disease, you can map out the motor circuits in the brain. Why do patients with Parkinson's have a stooped posture, a masked face, a tremor, right? Festinating gait, this sort of shuffling gait. And you're able to literally map out the areas all the way from the brainstem to the basal ganglia, these motor loops and motor regions of the cortex that are aberrant, and therefore know how to and where to stimulate and how to modulate. I'll now pass it back to Emily. We're going to go super quick through this. so that we have really virtually the whole second half for discussion.
Yeah, so I'm not going to spend a lot of time on this. It's just sort of a nice illustration of the sophistication of the kinds of techniques that we and others have developed to start to get at these questions. So this is a case where we took patients who had major depression and healthy controls, and we did a sophisticated kind of analysis. In this case, every column is a different subject, every row is a different brain area. The kinds of things we can do are seeing which areas of the brain co-vary with each other across the entire brain. This is a huge computational problem. It's very similar to the kinds of techniques that one does in molecular profiling and genetics. So we can actually take a lot of lessons from other areas and apply it to the brain. And if we do that, we can see that we have actually a pretty clean distinction between these two groups of patients, of subjects. And it turns out the ones on the left are healthy controls, the ones on the right are patients. And so we can start to look at the data itself to help us make distinctions between groups. And then we can do some AI, ML kinds of techniques where we can develop classifiers that tell us which are the areas of the brain, which of these regions is most responsible for this differentiation between groups. And we can map that onto the brain so that we understand what those areas are doing. This was really just meant as a high-level description to tell you that this is big data analytics, similar to many other areas of big data, but we can now leverage this to help us understand the brain. And with that, we'll turn it over to discussion.
Thank you both. That's totally fascinating. Why don't we pick up right where you both left off? Where does this take? This is fascinating, literally a window into the brain, or windows into the brain. Where do you take it next? I mean, how is this, could this be used, or is it being used now to develop potential new treatments?
Sure, so maybe I'll take that one. And so this actually gets to one of the reasons why I started a company to do this. In the research realm, we have been able to use this technology to see how different treatments are affecting the brain, and you saw some examples of that. But in terms of scaling this to use it as a tool to really inform the development of new treatments, we realized that fMRI, while it's been a hugely important research tool, hasn't made that what we call translational leap. It hasn't really been used in the clinic. It's been used in one area, which is pre-surgical mapping. So this is when neurosurgeons are about to cut into the brain to take out a tumor, to take out a region of abnormal tissue in epilepsy. Before they do that surgery, they may do an fMRI scan to make sure they're not cutting some critical regions of function. That's the only place where fMRI has been used clinically. But hopefully you've seen the power of this technology. Wouldn't it be so helpful if we can start to translate that and use it to help us treat these diseases? So one of the things that we're focused on early on is, well, there aren't great animal models for neuropsychiatric disease. When you're developing drugs in neuropsychiatry and the drug company goes through its clinical trial, the endpoints are all descriptive scales. There's no biology. And again, this is unlike any other area of the medicine. Every other area, when you're developing a drug, you have biological tools to tell you how that drug is working on the organ. And we don't have that in psychiatry. So starting from very early on, we can start to provide this information. We can show how in a phase 1 of a study where you're just looking at, is it safe, is it not safe, we can start to see how is it actually affecting brain circuits. And this gives really important information about the hypotheses that you have when you're developing that drug. Is it affecting those deep brain regions that David described that we think it should be affecting in order to alleviate symptoms? So you can start to get signals early on. And then, as David mentioned, we can start to then think about looking at separating out responders and non-responders. What does a brain that's going to respond to a therapy look like? If we can work on this and develop these markers while the drug is undergoing its pipeline development, then when the drug actually makes it into the clinic, we have a tool that can help guide patients to the right treatment, because we're able to measure their brain activity and say, well, there's a 95% chance that they're going to respond to this treatment based upon their pattern of brain activity. This is in the future. We haven't done this yet, but we are working on the first part now, and this is really a stepwise process. And so really the reason for starting a company, and I don't want to focus on the company because it's really the science that we're talking about, but the reason is because academia is just not cut out for doing this quickly, for doing this in a way that complies with regulatory, quality, compliance kinds of considerations that you need if you're going to make a medical tool. And so the goal was to really jumpstart that whole process by bringing it into industry.
Yeah, and may I just add a tiny bit? One other sort of corollary of all of this is that if a drug company or brain stimulation target is being evaluated, or psychotherapy or a digital therapeutic, which we can talk about as well, for that matter. If you can, what we call stratify, all depression may be called one thing, but if you scan 100 people, or if you study 100 people, you're going to have different flavors of depression. And we're going to get to the era where we can say that a given person has depression type 4B, because they have this particular profile of brain activity of frontal limbic dysmodulation or something like that. And that gets to other implications, because what you're doing then is starting to even redefine the taxonomy of these disorders and the classification of these disorders in a way that's much more akin to the rest of medicine. One final point, sort of on the neurologic side, is a lot of neurodegenerative diseases start decades before. Dementia and so forth. And part of the failure of drugs that have been developed is, although we're seeing some hope now with certain ones, but still limited, is that the horse is out of the barn. The damage, the deposition of these abnormal proteins and other changes in the brain is too far gone. And so the advent now of neuroimaging, where you can scan a person in their 40s or late 30s and start to see potential signals that there might be trouble down the line, you can intervene earlier with trajectory-altering therapy, which then gets you towards prevention, which is the holy grail. I don't want to overpromise, and we're not pushing the company at all. That's just an example of how this is being translated. But the science and the medicine is evolving to the point where at least these things are no longer pipe dreams.
So what can't you do? Like, what are the limitations of, this type of functional MRI? Like, the brain is so complex, right? And we have spiritual parts of it. And so right now, what can technology address and what can't we address, and how would you try to address it?
Yeah, I actually give a talk on the neurobiology of religious experience, so careful what you think can't be described. It's a bit provocative, but we're in an era now, why do patients with temporal lobe epilepsy all of a sudden become hyper-religious, quote unquote, when they weren't religious in their upbringing at all? Why do patients with manic depressive illness, bipolar disorder during manic episodes become very spiritual and religious, and the same brain, the same person, when they're in a different state, doesn't feel or think that way at all? And so really we're in an era where, and I don't want to be overly reductionistic, where you can say that anything that's in the realm of human experience, subjectively, mentally, or behavior, ought to at least have a correlate. And that's important, not to conflate correlation and causation. But in many cases, there are causative, lot of causative evidence. And so, but that said, to the spirit of your question, we're operating on the macroscopic, millimeter level on the order of seconds. There are other technologies like electrophysiology or magnetoencephalography that are not as good spatially at deep areas of the brain, but give you information of neurons firing on the order of milliseconds, which is really the order of time on which they fire. And so we combine these sorts of things. The molecular techniques that Emily was talking about before. So each thing has something that it's good at and things that it's not good at.
And I would also add that one of the limitations is that we're still understanding what does normal brain function look like. The brain is so complex. We have learned so much with these technologies. It's far from knowing everything, and so it's going to just take time.
I want to go to questions from you all soon, but let me ask one more and just broaden it out a little bit to talk about the period we're in, the pandemic, and its effects on us. I wonder, how resilient is the brain? I mean, how much damage has been done in the past 3 years, particularly with children, that might not be recoverable? Is it? And, is there a permanent effect on children and adults, do you think?
Yeah. So I'm glad you used the word resilience, because that's something else that we're studying and people are studying. It's not just about the things that go wrong with stress and mental illness. It's about why do two people go through the same trauma and one person gets PTSD and the other person comes out having a new sense of life and starting a charity? What are the things that make a person resilient in the face of stress, et cetera? And it turns out that we all have certain genetic predispositions molecularly for risk or resilience for all of these things. We have neurodevelopmental processes during pregnancy and up until the 20s, late 20s, where the brain is developing and myelinating, and experiential things like abuse, neglect, trauma, violence can affect this for ill, or enrichment can affect it for good. And so we need to understand resilience as well. In terms of COVID and these sorts of things, and even before COVID, there was a rise, especially among teenagers, of mental health problems. There's the whole question and data about social media usage, and on. We can talk about if people are interested in. There are generational effects that are profound. And a number of complex multifactorial reasons for those that we're understanding more about now. But to your point, and there's a concept called allostasis of the amount of stress that we cumulatively each have had in our life. Is there a tipping point, and is that threshold different for different people for these sorts of reasons? And how can we reset that? And how can we add to the thermostat, if you will?
And some of the other factors that go into something like COVID are what are the physiological effects of the virus on the brain. We know the virus most likely enters the brain through the nose, through the olfactory tracts, goes into olfactory cortex, that's your sense of smell area of the brain, and then tracks into areas that are close by, areas in what are called the limbic regions. David mentioned some of these. Amygdala, important for emotion and fear. Hippocampus, important for memory. So we're still learning how the effect of the virus in terms of its effect on increasing inflammation, et cetera, cytokine storms, all of these things have affected neurobiology, and we're just in the early stages of starting to understand what those longer-term impacts are going to be.
So why don't we start taking questions from you all. Who's got right here?
Are there, you spoke about schizophrenia and depression. Are there particular disorders that this approach is better for, or ones that works less well for?
It's turning out to be good for all of them. There's certain questions about. Yeah. The question was that we mentioned schizophrenia and depression. Are there certain disorders that this approach is better for than others? I will say that the ones that are more severe, the ones that are more than 2 standard deviations from the norm of brain function of a certain sort, are easier to pick up profiles of, although we now have techniques that can even pick up very small signals and pull them out. But even things like personality disorders, you may have heard of borderline personality disorder and things like that, which people, and personality per se, temperament, things that are thought to be, quote, very psychological, are amenable to identification this sort of way. And one of our studies, we decided for reasons of time not to show a slide of it, was looking at the brain in borderline personality disorder and how it has difficulty modulating emotion and behavior.
Another question over here. I can't see who's raised their hand. Yeah.
So a question along the same lines, if you think within a disorder like depression, I'm just thinking about the patient journey to getting diagnosed with something like atypical depression or treatment-resistant depression. Is this sensitive enough to differentiate between those and maybe shortcut the path to that diagnosis?
That's the hope. That's the hope, but it has not been proven yet.
Do you need to?
Yeah, the question was, in a patient's journey with things like treatment-resistant depression or atypical depression, something like that, is this sort of approach something that may help shorten the trajectory between a problem or a diagnosis and a treatment? And the hope is yes.
So I see we have a. Sorry, we have a microphone.
A hope at this
Before
point.
we continue, we have a microphone for Q&A, and after you raise your hand and are picked, it will be given to you.
Just wait for the microphone. So, is it Hillary? Yeah. Wait. Turn it on. We can master the technology.
By the way, I could tell that you guys were related.
Okay, so maybe it's an oversimplification. I'm just a simple radiologist, but maybe it's an oversimplification in terms of sort of the concierge tailoring of the drugs or finding the ones that might work or might not work. I understand you can't have an animal model, but you showed things turn on in yellow and green and turn off in purple. Is it that you look at how somebody responds to the drugs and see what turns on and turns off? I didn't really follow.
So what you can do is you can do a scan before the drug is given. You give the drug, and then you can do a scan afterwards. And then there are a couple of different things you can do. You can see how does the drug modulate brain activity, which areas go up in activity, which areas go down. But the other thing you can do is go back and look at the scan that was done before you gave the drug and see what are the patterns, and you do this with mathematical modeling, what are the patterns that are associated with a subsequent positive response. And we can do this even to a symptom level. So for example, the study that David brought up in borderline personality disorder, we were able to identify patterns of brain activity that were associated with subsequent response that were different for looking at anger symptoms versus affective lability symptoms. So there's a lot that you can do in terms of the modeling, the analytics, et cetera, to pull out different things from the data.
Next question. Is there anybody who's had Kirsten? Yes, you should wait for the mic.
Where are we going?
Unless right front row.
Is this on? Yeah.
Yes.
I'm wondering what some of the barriers might be in terms of bringing some of this to scale. I'm especially diagnostically, so I do some work around the issue of autism, and my understanding is autism, for a long time, we've sort of known that functional MRI scanners show distinct patterns in people with autism, and early diagnosis is incredibly important to using the developmental window of early childhood for treatment. So what is it that's kind of preventing us from using a more sophisticated diagnostic tool? We're still heavily reliant on, a year-long waiting list to see a certain type of doctor who can look at behavior and say, oh, that's, autism, or this could be another disorder.
So one of the barriers has been that this kind of technology is, as I said, really focused in the research realm today. It hasn't made that kind of commercial scalable leap, and so most of it is found in tertiary academic medical centers. So again, not to plug our company, but one of the reasons that we're doing this is we've developed a platform that can be easily scalable, and there are a lot of technical things that go into that scaling, which we won't get into. But that has been a challenge, and we have sort of systematically addressed each of those technical hurdles because our goal is to get this out into community hospitals so that it's no different than going and getting, say, an MRI scan for a torn ACL in your knee. We're not there yet, but that's one of the reasons why we're doing this, is to make it accessible.
And just to emphasize that the science comes first. There are people who make premature claims about things and charge people money, and that's charlatanism, right? And unfortunately, it exists in the world. And so something can and should make it into the clinic if and only if it is scientifically proven and replicated, etc. And we're not there yet.
Is there anyone who's had their hand up for a while and I haven't called on you? Just wave, because I'm sorry. There. Right in the middle here. Just, you could talk loudly.
I guess my question is, with this technology, have you been able to infer or explore the physiology of possible different meditative approaches that may are following one's breath or expanding one's sensation to include more of the body? And in a way, when you're talking about the Holy Grail, what we've always called clinical has gotten more, the line has moved more and more towards the subtle, and now we're getting pretty subtle in an ability to clinically identify something. And so I'm sort of thinking about the possibility of a general practice that people can follow, that maybe begin to be inferred and maybe applied in a more of a public health scale. I think maybe we're kind of all heading there in a certain way, and I'm wondering what you have there.
Yeah, absolutely. We've studied mindfulness meditation, as have a lot of people. And, in different cultures throughout the world, there's thousands of years of practice of the mind the brain learning how to modulate itself in ways that reduce stress and can help with lots of things. It's different when you're talking about a more diagnosable, more severe thing, but it can still help. And so it turns out that mindfulness engages very specific regions of the brain. And you may have heard about things called the default mode network and these other networks in the brain of when our mind is wandering or when our mind is focused and so forth. And we're able to tease that apart now and try to use it to improve mindfulness, if you will, or make it more efficient. And you can do it in a quote, non-religious way and not necessarily the whole thing. Not everyone can sit still for a while. Are there certain things, you mentioned focus on the breath and so forth, that we understand more and more of the physiology of? And this is, so and that can have public health sorts of scale. Yeah.
And just another sort of interesting extension of that is people in research are starting to look at things like biofeedback while you're actually in the scanner. As you have increase or decrease in the activity of certain brain regions, you have a visual representation of that, and you try to modulate that to affect your brain activity to get to a different level.
And could I just ask one more follow-up? In that, as I've aged, I've noticed, when you spoke about the tipping point of the accumulated weight of either a condition, but the subtle condition is just memory and personality acquiring a certain idiosyncratic constriction or whatever. And those are subtle things that don't get noticed unless, you might begin an intentional objective, so-called objective practice. And then I've noticed that it's actually possible to have a different view, like I'll have a view of my day and my life and of being constricted and not having possibilities, and then after a bit of a practice or just following, being a little bit attentive, my entire day and outlook is radically different, and that's a health issue. Because it leaves physiological traces.
Yeah, there's a whole area of science called mindset science, and there are neural correlates of that as well. I also want to very quickly mention, there's a lot of talk now about psychedelics and so forth, and it's been shown that psychedelics modulate these circuits in the brain in very particular ways, and in ways that accord with some of the things that are described all the way from mystical experiences to certain therapeutic neuroplastic effects.
We have just a few minutes left. I think Mark had a question here in the front row. Right.
Thank you, and it's great work and exciting to see what you're showing here. And I'd like to follow up on this last speaker. This is a very hyper-medicated society, and maybe the DSM-5 has helped. This type of method can help to define new medications. But the other thing, as was related, that many of these tools could potentially exist within ourselves. Meditation, cognitive behavioral therapy, which is still an intensive therapy, but is not necessarily dependent on pharmacological responses. And so my question is, some of these things that you're imaging are related to CBT, as you mentioned, meditation. The opposite side of things, of course, is there's an epidemic of marijuana use as well, and that also has an impact on executive function and brain development. And so that you didn't speak about that and potentially at that role. But it just brings up a whole public health aspect as well about, is it within ourselves to deal with many of these problems? And if you talk about the public health of mental health, it's actually whole societies which are, I'll use the word crazy. I spend a lot of time in Scandinavia, which are known as the countries as, quote, the happiest countries. And they don't have anxiety. And the reason they don't have anxiety is because many of the basic needs are taken care of. We don't have that here in many parts of the world. And so I'd just like to bring that up as a public health issue.
Yeah, certainly whatever can be dealt with without medications should be. What one sees is that for more serious things, medications and other somatic treatments can be life-saving, and you can talk till you're blue in the face, and the person's not going to get better, and they can't pull themselves up by their bootstraps, and it's not their fault, and they may not be aware of it, et cetera. And so I think, like anything, for heart disease, for mild things, there are certain things you can do behaviorally and you should do prophylactically. But if you have serious heart disease, you want to see a cardiologist and you want to be on medicine and so forth. And so a lot of times people think medicine's not natural, but then they go to the herb store and they take, things that are toxic an SSRI medication just modulates your own natural serotonin, et cetera. So there are a lot of sort of mythologies around all of this. In terms of marijuana, with the legalization, it is related to decreased executive function. It can increase chance of psychosis in adolescents and early adults. And so, yeah, I have concerns, actually, medically, in terms of all of this. On the other hand, there are parts of it that many people are very much in favor of for reasonable reasons. So I think as a society, we have to address all these things. Finally, to your sort of meta point, I'm very involved now with sort of neuropolicy, if you will, because I agree with your terminology. I think our society and many societies are sick, and we can try to understand the forms of maladaptive group behaviors and dynamics, and see if what we learn about the brain in an evolutionary context can be applied in trying to improve conflict resolution, polarization, all of these sorts of things, which are getting more and more, especially with technology, to be problematic.
And I'll add just one other thing, which is that I've recently gotten to know a number of small companies that are working on other alternative public health approaches. So, for example, peer support, other things that we can do in addition to sort of more formal medication, et cetera. Are there ways that we can set up support systems within society that can help to address, for example, in young people, early signs of mental struggling, to try to prevent getting to the point where it becomes a full-blown mental illness. So we really have to think about it holistically. What are all of the things that we can bring to the equation to try to stem this process? And we have to be creative about it.
And you've heard a lot about digital apps. There's a new one every week, et cetera, most of which are not sophisticated clinically, some of which can be very helpful. But there's a whole new world now of sort of in the digital therapeutic space that's very, very active as well, and that may bring to more people access to helpful things. But when a certain line is crossed, then, you know, it's a qualitatively different thing that needs a different kind of treatment.
Let's go, we're already running over, but let's go to one more question up here. I'm so sorry for those of you who we didn't get to in the back. Please come down afterwards. This is a really, really important discussion, and we could be here forever, anybody who...
So congratulations. I'll finish it off. Congratulations. It's spectacular, the work you've done, and that you've made a company to do it, because I still believe capitalism works, and it'll be the best way to get an answer. But
If we can get funding.
Yeah, well, I'm about to give you the answer. I'm about to give you an answer for one thing. A huge problem is CTE, where there is two great sources of funding. One is the Department of Defense would be incredibly interested in this, and there's almost, I won't say unlimited source of money, but huge source of money. The other is the NFL, who feels now that they have to either defend or answer what they're doing. And I think I would at least recommend to you that you get connected with those people, because there's a huge number of patients, or subjects that you can study over time and see, to your point, whether it's predictive, your techniques are predictive, I believe they will be, and is an early diagnostic for CTE and those kind of things. So I was just going to say, if you've done any of that, if you haven't, I strongly recommend you do.
So absolutely. Coming from the academic world, we're used to reaching out to these organizations for funding. And so, yes, and one of the nice things, of course, with getting government funding for a company is it's non-dilutive, so that's an additional bonus. But yes, so we are targeting DoD, NIH, BARDA, ARPA-H, et cetera. So we are on it.
And we've done work in traumatic brain injury, but part of the problem is that in certain regards, NFL or the military doesn't want to expose risk.
Right.
And if you find something, there's a lot of incentives in the other way, and so it's very tricky with these sources of what they want to know and how fast, I hate to say. But that said, I think the DoD is taking things exceedingly seriously now, and there are signatures of traumatic brain injury that are reliable.
Yep.
So are you guys able to stay around for a few minutes for questions? Absolutely. I'm so sorry that we have to end it, but this is wonderful.